prestige lecture, and we're very grateful that she is here and that we can learn from her in this prestige lecture. We also want to welcome Prof. Bohman, who is the program leader of the program in which Doris does her work, and then all participants, also those who attend by watching YouTube. About our program, Prof. Doris will do her prestige lecture just now, and then we'll ask Prof. Roos to just respond to the prestige lecture, and then Prof. Hoffman will present the certificate of Professor Bohman. And then there will be some photos here and at Potential House, where we will have some refreshments as well. I also want to thank our support staff, Lynn Weston specifically, and Annette Jordan, who really played a big role in putting this event together today. The question is, why do we have relationships with extraordinary professors at the Noordwes-Universiteit and at Potential? We build these relationships with national and international experts to create a space where we can share experiences, collaborate to work on individual, relational and societal challenges, to advance science, and to empower our researchers, our students, and build capabilities to conduct research. So our extraordinary professors are critical contributors within our research entity. Prof. Doris Bohman will address us this afternoon on Gerontechnology and health communication. As I said, she's an extraordinary professor at Potential currently. She's also an associated professor at Department of Health, Leckinger Institute of Technology, and holds a PhD in medical science with a focus on gerontological care at Karolinska Institute, and has extensive experience working with ethnographic methods. Her PhD studies had an ethnographic approach focusing on caring aspects of older individuals in a South African context. During her PhD studies, she was also a visiting lecturer at the University of Pretoria. Her current research focuses on different aspects of cultural competency within healthcare and education, and the use of technology in a health context to grasp the user perspective, enhance intergenerational links, and develop tools to make daily life easier for older persons from a health perspective. So, Prof. Doris, we really welcome you to Potential, to the Noordwes-Universiteit, and we hope that we will still have a very good and productive relationship with you. And we look forward to your prestige lecture. Thank you very much.
Thank you. Yeah. Mm-hmm. So, let's see. Yeah, thank you. Yeah. I'm just waiting for my presentation. Thank you so much for your kind words, and it's a great honor for me to be here today. As you know, I'm from Blekinge Institute of Technology in Sweden, so I start with a picture of the same kind of mist or fog as you have at your campus, as we have at our campus in Sweden. The topic of my presentation is Gerontechnology and health communication. And I have made an outline. I will take you a bit into my background, or background of the Gerontechnology approach, health communication, and then some reflections on future. I would like to start with giving you some aspects of my background, why I'm here today in South Africa. I started my career working as a nurse, and then I've been in health education for more than 20 years, but I've had some, other experiences too. I have worked with the European framework, which is a research program. So I've learned the hard way how to do applications and to not promise too much, because you have to eat it when you have to do your reports. So. Cultural competence is a very important issue in health education. You can't work with health without thinking in what context you are doing your daily work. So I have introduced cultural competency courses at my university, and I've also been involved as international coordinator with students, and most of them in the collaboration with South Africa. I just wanted to show you some of the Linnaeus Palme collaborations from year 2000 to year 2019. Started with University of Pretoria, then University of Limpopo, Noordwes-universiteit, Medunsa, which has a new name that I don't want to say because I will say it wrong, and Botswana and a university in Kenya. My research focuses on qualitative methodology and, as we said earlier, an ethnographer, which means I'm interested in people and how they act. So I'm always observing. Yes, I got my PhD from Karolinska Institute in Stockholm, which is a very medical university, and then you think a nurse in the medical science field. But within Karolinska Institute, we have different aspects of being old. So gerontological care was one area. And the ethnographic approach was my own choice, because I thought if we are going to have a collaboration with a university on the other side of the earth, I need to understand how people think, or at least try to understand. So the ethnographic approach was the one I chose. Why gerontological care? Yeah, as we know, the demographic is changing. There is an increasing number of older individuals globally. And one of the questions I've got in Sweden was, why are we going to South Africa? Do they have older people there? Yes. Maybe not so many as we have in Sweden, but enough. And they have a very different role from older people in Sweden, I would say. If we look at the number of people over 65 years of age in Sweden, it's 20%. I don't have the numbers for South Africa, but it's a growing number. And the gerontological care approach was also to get a contextual approach to the subject. And we combined Swedish and South African researchers to get a broader and more enhanced knowledge. We have also an aging minority, a lot of aging minority communities in Sweden and in Europe, so we need the knowledge. Yeah, the site was Mariannäng in Hammarskjöld. Why we chose Hammarskjöld was because it's a site where you find a majority group of Africans. Few studies had been conducted when I did my study, and the focus was daily life, being old, and health and illness beliefs. So it was a broad spectrum. I had to do field work, you know, being white in a black community, you can't really be invisible. Everyone sees you. So from the beginning, when I was had introduced me and had the participants, and said, I'm going to follow your daily work. Everyone sat down. Nothing happened because they was just waiting. So being invisible, it took some time. But what I did was that I did a lot of interviews, focus interviews, and I followed them in their daily work. And of course I had interpreters. That's also a challenge. If you have English as your second language and then you don't really understand the languages they were speaking. But I had an interpreter, and during the course I learned something, but yeah, that was a challenge. And I spent extensive periods doing my field work, so I think I got like a picture of it. We also worked together with Sangomas, or worked together. I wanted to understand how their approach of Sangomas. I have learned that there are very different aspects of it. Why it was of interest was because we wanted to see how one approaches and when one uses the healthcare system. They talked about European doctors and their own doctors. The articles that were published from this study was the first one: we clean our houses, prepare for weddings and go to funerals. Daily lives of elderly Africans in Mayaneng. If we compare this with Sweden, it's very different. When you get over your retirement age, you live your separate life from where your children are. In this aspect, the older people had to be involved for different reasons in the life of their children and grandchildren. And then the next study was on South Africans' experiences of being old and care, of care and caring in transitional period. And in that study, we could see that most elderly people care for others instead of being cared for. Tradition in transition was a study on the intergenerational relations. And during that study, I got a chance to meet children and grandchildren, and also to understand the role of mobile phones. And at this time in Sweden, mobile phones were used by older people, but there was like big ones with big buttons. But in South Africa, everyone managed with bad sight. They could manage the mobile phones, but of course for very low level, but they used them. The last one was about health and illness beliefs. Yeah, as I said, the essential differences between Sweden and South Africa was the use of mobile phones and the connections between the generations. Not always by choice, but forced to have a relationship. So it's not like a romantic view of Africa. This highlighted the question of how we can use mobile phones in the life of older people in South Africa. And this is also highlighted the question of how we can use our field at Blekinge Institute of Technology, Applied Health Technology. And one part of Applied Health Technology, which is a transdisciplinary research area, is Gerontechnology, which is a combination of gerontechnology and gerontology and technology. Sorry. And what is gerontechnology? It involves techniques, technological products, services, and environments based on knowledge of the aging process. A bit complicated to say it. So why is gerontechnology a prioritized area? Yes, what is happening? The infrastructure to take care of older people is not enough. We know we don't have enough resources to take care of all older people. The situation in Sweden is still manageable, but if you look at other countries like Japan, they have such a shortage of healthcare professionals, so they are starting to look for new solutions. Maybe not robots, but something in that direction. And health technology in healthcare is often seen as a key enabler for gaining efficiencies in care. And as a nurse from the beginning, I know you can't replace human beings with robots, so one has to be careful. Maybe in one aspect you can save money, but in the other aspect it costs. Not enough professionals to take care of the frail older population is also something that is a global phenomenon. One reason is the salaries. Another reason is it's not so, people are not so appealed to work with older persons. If you work as a nurse, you want to be in emergency, or you want to work with, everything that has to do with quick responses and quite easy solutions. What we have done in Sweden so far is that we have started to recruit nurses in the municipalities, and we also offer them the ongoing training and better salaries. It works in some municipalities and not in others. In the Swedish context, there is this transition from clinical practice to home-based care. Care close to home. Health technology will become one important aspect. We don't have enough money to have big, complex hospitals. Instead, care will be done at home. And when you have care at home, you also need to have the qualified staff members, and you also need to have the equipment. So if someone says that it's easy to work with patients or older people at home, it's not easy. It's much more demanding, and you need more qualification. We also everyday life context. The gerontology or the technology can support individuals to remain healthy and to live a good quality of life. So that's one aspect. We want to stay at home as long as possible and keep us as mobile and as cognitive in good shape as long as possible. The twin challenges of an aging population who live longer and the burden of caring for chronic conditions is one reason to introduce gerontology also. For you who doesn't know, it was established, it's a young topic, established in the Netherlands in the end of the 80s and beginning of the 90s. There is an international society of gerontechnology with yearly conferences. I'm not going to say if it was someone I met there, but Gerontechnology has also a journal, so you can publish. And if I continue with gerontechnology, there are some age-related changes where gerontechnology can play a role. You know, your eyes get worse. You need some kind of assistance. Your mobility is not as it used to be. I was crawling in a cave this weekend, so I know. When you get older, you have to have some kind of assistance. Cognition, you have to you remember some things and some things disappear. Functionality, yeah, it's also, and age-related diseases. And nowadays in Sweden, we have the phenomenon of multi-diseases. You don't arrive to the hospital with one disease. You have probably high blood pressure, you have something with your heart, and you have something with diabetes, and so which means that your care is much more complicated. And it's important to measure and identify the effects of aging. And we had a workshop this morning with the members of SNAC B, which is the Swedish national study on aging and care. And that's one of the studies that are conducted at Blekinge Institute of Technology. We also have a study called NEAR, which is focusing on national infrastructure for research on aging in Sweden. There are a lot of individual studies, but we need to have more, everything in one big database. And I'm not going into that because we talked about it this morning. Yeah, how can we create an environment to support multidisciplinary research? Well, we tried at least at Blekinge Institute of Technology. During my time as head of department, we introduced a BTH research and education clinic. And at the clinic, we tried to establish collaboration between engineers, technology, and health. And you know, when you try to merge different subjects, it's always in the beginning a fight or who is going to get most space. But there have been a success. We have a lot of different projects going on, and one should say it has to be. You need to have a good budget, and you need to have a good team to work. But Optentia, I think, is something like the same. Yeah. Then I also want to add something about what is happening in Sweden on national level. I know if one wants to introduce gerontechnology in South Africa, that's one thing. And we, as a high technology country, are struggling with things that you maybe think is not the case, but that's the way it is. On national level, a governmental funded project was launched in 2020. And the reason was to promote the introduction of health technology, or as we also call it, welfare technology, which is in the field of gerontechnology. In Swedish, digital teknik med äldre i fokus. This project introduced also a competence center to support municipalities in implementing health technology and welfare technology. And this competence center is on, as I said, on national level. And it was a good start. And the project was in line with the Swedish vision for ehealth 2025. And as you see, it's a bold statement. It says, Sweden will be the best in the world. Now I'm going like this. At using the opportunities offered by digitalisation and ehealth, making it easier for people to achieve good and equal health and welfare, and to develop and strengthen their own resources for increased independence. Yeah, I mean, it's not so far away, 2025. So we'll see. But you should start on the top level, and then you have to accept reality. I also want to give you an example of different solutions in old age care services, so you know what we are dealing with. These are the most common health technology solutions in old age care services. The first one I want to mention is digital safety alarm. Alarm in the home environment used by older persons to get assistance from care staff, and it has replaced landline telephone. And I know from my research in South Africa, not many people had landline telephones, so in that aspect you are already there. The alarm is connected to staff or to alarm central, and this is mostly people have like a button that they push and then someone comes, hopefully. That's a digital safety alarm. Then we also have something called passive alarm, which can be linked to a carpet, to doors, or two sensors. Alarm activated without involvement of the older person can also be activated due to less activity. You know, if one doesn't go to the toilet or don't open the refrigerator, it will be alarm after a time. So it could also be seen if someone is eating a lot. You know. Medication reminder, that's a technology to remind people of taking the medication and that they are taking the right dose at the right time. Then they have, in some facilities, medication robots. So one has to be really careful so not the wrong person is getting the medication. But it has worked quite well. And it is also often combined with the audio signal. Then we have safety cameras placed in the home, in the environment, for a kind of supervision. And the camera is used at certain times, and the rest of the time is offline. Most used during night replacement, replacing a physical visit. And then I can take the example of my own mother. When she lived at home, still living at home, she got the question, because you get asked, is it okay if we put a camera in your bedroom? And she said, what? A camera in my bedroom? No, thank you. Do you want to have a camera in your bedroom? Yeah, so that was out of the question. No camera. But I think it was a good example. You can choose. It's not by force. And then we have digital lock, key-free homes, and electronic lock. And when I was writing about this, I thought about South Africa. You're much more advanced than we are with all kinds of safety systems for locking and the locking system to replace keys for care staff also. Sometimes it's difficult to get into the house of someone that might be a bit confused because of cognitive impairment, and then one can use the digital lock. And then of course we have cats. Robotic cats, which is very expensive equipment. Maybe there are 2, 3 in Sweden. I don't know. If I'm not going to say my own personal view about it. Incontinence and sensors, that's quite good. And the shower robot I haven't seen, but you have to be careful. Suddenly someone is going to give you a shower. And intelligent toilets, yeah. Which means that the toilet recognize what kind of products you are producing, if I may say so. And then we have the digital lock and also a medication reminder. Usually you don't have that in your home, you have it in a facility with several people. And then you can have this GPS alarm. You know, when you get a bit confused, maybe you go out and you may disappear if you go too far. And the GPS alarm tells the central or family members that you are leaving the area. You are going off the fence. So then they can also be alarmed. I don't know. We are talking about solutions that are very much trespassing your private zones. So one has to be very careful. This is in Swedish, but I can say that municipalities, I did a translation, with health technology, welfare technology for individuals living in their own home. This is a study that have done 2016, 17, 18, 19, 2020. And if we look at these systems, you can see that digital safety alarm is more or less 100% 2020 in Sweden. And the passive alarms is number 2, I think, which is like sensors. And digital planning device for the staff members is also growing number. And the rest is digital lock and safety cameras. And use of health technology or welfare technology among users with extensive care needs. One can see that the digital alarm is the number one, and then digital lock. And the rest are more or less the same. So the alarm function. And then one can think, why is the alarm function the most used? This is because of staff shortage. We don't have enough staff, which means that you have to have sometimes solutions which is not the best for the individual, but to have some kind of an organization who is working. Yeah, what is this then? It's a flat where staff members and also older persons who want to know about new technology solutions. This is just an example where they can go and check if they want to try it in their own home. This report, or this digital technology focusing on older people project, have had an interim report which says that from the beginning of the project up to 2021, health technology solutions have increased in the municipalities, but the development is unequal depending on if it's a rich municipality or poor, and the knowledge of the user perspective is lacking. There are not enough people who know how to use it. And also the ones who are the receivers, I mean, they don't know how to use it. The cost efficiency is particularly difficult to assess because there are a lot of new products and no one really knows if it's going to be sustainable. So more knowledge is needed both on the needs and the functions of health technology and the effects to estimate its usefulness and cost efficiency. So what they are saying, we need more studies, more research. If I go back to the collaboration between Sweden and South Africa, and what I saw in my studies about mobile phones, I also want to mention the collaboration I've had with my colleagues from Noordwes-universiteit. What we did, we planned the project in Oxford, yeah? Yes, and then we did a pilot where I was involved called, how do we say it, Ignite. Yeah. Intergenerational networks through information technology. And then you followed up with your project on We Deliver. In that project, some articles were produced, or produced is not the right word, they were, yeah, we say produced. Example from the South African pilot study was that the majority of the people in that study mainly use two functions of their mobile phones, to make and to receive calls and texting, which was also what I saw in my study. It's very simple, but it works. And we also saw in the project that older persons resort to other people to assist them, in this case children and grandchildren, and constituting mobile use by older persons as essentially an intergenerational project, which means if you help me, I help you. If I can have a mobile phone some days, I can help you with it other days. Yeah. So it was like a negotiation between generations. And this was something we published also. Another study was that another article that we published was the findings show that older people's low level of competence is preventing them from accessing information, which is also something we knew, that if you don't really know how to use the mobile phone or how to get the information, then you don't really appreciate the mobile phone or the information through the mobile phone. So health technology is depending on the response from the receiver. You can do all kinds of advanced products, but if the receiver doesn't understand, then what's the use? In communication, one area is health communication, which is targeting communication targeted toward health issues, a multidisciplinary field including influences from marketing, sociology, behavioral sciences, and anthropology. And the main goal is to inform, influence, and motivate individuals, institutions, and public audience about important health issues. And one area is technology-based health communication. And it's more or less the same, but you use a device which is technology. And the device we had in the studies we have done was, of course, mobile phones. We have also done concept analysis in Sweden about, oh, sorry, I should say this, health literacy is the word to understand the use of information. Yeah. And the levels are mostly very low in those studies I've been involved. And then we did a concept analysis of health communication. And what we found was that tailored information and mediated messages are significant for older persons. You can't just send out the message without having had a conversation with a receiver of what they actually understand and want. So that's what that study showed. Technology-based health communication could both facilitate understanding and also be a barrier. Which says, on the one hand, it's good, on the other hand, it's not so good. And of course, the home environment influences health communications in terms of social aspects, such as the interactions and habits of the older person and the informal caregiver. In the Swedish context, we talk about informal caregivers. In South Africa, yeah, it is informal caregivers, but maybe not using that terminology. And then we did a study on older persons with cognitive impairment and their experiences of using not a mobile phone, but an iPad. And what did we find? Yeah, they say the same. It's both challenging and it gives possibilities. And mobile technology was related to the perception of being helpful, easy to use, and fulfilling of needs. And the participants' differences in abilities affected preferences, relevance, and choice of health communication sources, either mediated by technology or not. And sometimes they said, oh, this iPad I have is too big. I prefer to use my mobile phone. Or they said, oh, I have it on my paper, so why should I have it? So we shouldn't, how to say that we can't use paper. Paper is still relevant. And then they said, I can't have it in my handbag, so I keep it home and take my mobile phone. No. So there was different reasons. And the participants' skills and expectations contributed to perceived benefits. Having support with this application was very essential. If they haven't any support, they just put it somewhere far away. And what we also noticed was when you develop something, they should always be part of the design. If you don't do that, it's not going to work. And then someone will say, yeah, why did you use this particular device? It was a project where we were not involved in the design process. Then we got the result that it didn't really work. And personal support also improved the usefulness, yes. If it was the informal caregiver or if it was someone from the home-based care. But number one is personal interaction with formal caregivers was also considered positive. They want to see someone from who works with the healthcare or home-based care. And then we have those who are very much most important, the informal caregivers, especially if you are dealing with someone with cognitive impairment. Sometimes we say that if we have someone with cognitive impairment or dementia, that's a very sad diagnosis, and it shapes the personality. But who is most affected? It's not the person with dementia, it's the person who takes care of the one who is demented. Or they often become involved in care and play an important role in assisting and supporting. So there are a lot of people who do this work in silence, and they need support. And one way to get support is through using different ways of health communication, together with face-to-face meetings. And then you can compare it with the intergenerational project in South Africa, where the older people are both caring and cared for. And I must say, when I did my study, now it was a study with few participants, but dementia, no one talked about. Yeah, one could talk about dementia, saying that someone had been bewitched or something else. It was nothing. Not often one talked about relatives who were demented. So what are the factors playing a vital role in implementing gerontechnology? One crucial aspect is development of partnership between the user, which is both the older person and informal caregiver, and care providers. It's not something that you can force people to use. You must do it in partnership. And context sensitivity, we can't develop a model in Sweden and implement it in South Africa, or vice versa. You can't come to Sweden with your models. So it should be diverse and locally situated, and we should avoid traveling models or theories. And it's to implement new technology in healthcare settings are very complex. It's nothing we do in, in a very simple way, because we are affecting already structures that are working, that don't want to have the new technology. They want to have it as it always was. And one reason is that on manager level, people are not always so keen to change. Maybe those who are working with the devices want to use it, but the managers want to keep it. So they are a very crucial group to have involved in this aspect. And new technology may result in intended and unintended organizational consequences. Yeah. It has to do with the one I said before. And a very important aspect is to protect privacy. You can't disseminate private information around a group of care staff. In Sweden, we have a system at the hospitals and also in home-based care. If you are involved in care, you are allowed to look at the journal, because all journals are in computers. It's not on paper-based anymore. But if someone in the same group who is not involved with the patient go and check the journal, that's an offense. You can lose your job if you do that. So that's one way to protect privacy. But when we collect health data, it's also where do we keep the data, and who is able to get hold of it. Or if we disseminate information, then we also have to think the numbers of people involved. In home-based care, it's not like in the hospital, there might be 3-4 persons are involved. It's up to 10, 15 persons. That's a challenge. And one crucial point is that you always have to have ongoing training, education for social and healthcare professionals. That's the only way, because this knowledge in this field is changing from one day to another. So one can't say, now we have established this course, now they have done it, and now it's ready. They have to continue, which costs a lot of money. So, that's also when you have to fight about budget. And conclusions from this digital technology project, SAS, the one that is still going on. One needs to plan how the results of the investment will be managed in the next phase. You can't just start a project and don't think about the next phase. So planning is crucial. And this competence center that was established need much more support and networks, because they have a competence center, but no one used it, or very few used it. And one needs, as I already have, it's like a repetition, involve patients, service receivers, family and staff. They need to be involved in both development, implementation and evaluation of introduced technology. But also if one change work routines. And to develop more knowledge in the field of health technology, both on national and local level. So more knowledge is needed on the functions of the technology, effects, benefits, and limitations. So now we know that new products are introduced to the municipalities. So in one municipality they use one product, and in another totally different, and then you can't work together when it's that kind of broad. And it's crucial to coordinate the development of knowledge involving all levels, municipalities, regions, universities, and research institutions. So we have the point of departure should always be the patient or the older person. I shouldn't mention them as patients, because first you're just an older person and then you can become a patient. And it's important also to develop tools for quality assurance and cost efficiency on local level. Yeah. So, hello, it's me, the future. One could say, lastly, this picture indicates that we are already in the future. That was a long time ago. I remember the first mobile phones. There was like a big box, and then you had and listen. But this is also a very old one. So we are already in the future with its possibilities and challenges. Thank you. And now? No.
Thanks, Doris. You can leave hello to the future. I think that's relevant for minute to minute in our digital age. So Doris, what started in Oxford as an informal conversation with Jaco, myself and you, ended up today with Oxford, Noordwes-Universiteit, and your appointment as an extraordinary professor. Your lecture confirmed the interrelated trends of an older growing population and technology advances that present unexplored opportunities. We learned from you today that Gerontechnology is that subject discipline, on the one hand focusing on technology developments, but also on the other hand the potential to support people in their familiar environments for as long as possible. You emphasized the importance of context, and I was reminded of the research that we had just completed and that's being presented in a book that Jaco and I edited. And you talked about a security system, and some of our older individuals talk about a dog as their security system, and emphasizing the importance of context and local relevance. But how exciting it is to think about the possibilities and digital solutions in this local context that we are involved with, you in Sweden and making the transition to South Africa as well. But being from Sweden and doing research in a cross-cultural context shows your commitment as a scholar and demonstrated your deep sense of curiosity and drive to make the aging world a better place. For your research, you wanted to become invisible. but your contributions in the field of gerontechnology are not. We are excited to have your expertise here in Abtentia, combining the needs of all the growing populations with technology solutions. And an additional bonus is to working with a humble, nice person who is also a rigorous researcher. Welcome in the Aging and Generational Dynamics sub-program.
Dear Doris, it's now my honor to present to you a certificate as an extraordinary professor at Northwest-University. So we're delighted to have you here at Northwest-University, and particularly at our research institute. And I just, in my mind's eye, see how productive and creative our collaboration will be. Thank you very much, and welcome.
Yeah, thank you.